it doesn't cure the disease, but what they do is that they slow the progression of the disease.
Here you have a drug that actually takes out the biological marker of the disease and flushes it down the toilet. What do you tell people in terms of what they can expect from these drugs?
On this episode, Dr. David Reuben sits down with Dr. Alejandra Sanchez Lopez, a cognitive impairment and behavioral neurology specialist. They're talking about the new drugs that can actually remove Alzheimer's protein from the brain and what that means for the millions of families watching someone they love start to forget.
Hello, I'm Dr. David Reuben. I'm a geriatrician, and I'm delighted to be here today with Dr. Alejandra Sanchez Lopez, who is a very unique physician. So, Alejandra, can you say just a little bit about your background? Because you're kind of a one of a kind.
Sure. Well, I did internal medicine right as my in my residency, and then I continued doing geriatrics. But then I did another fellowship that was behavioral neurology. So basically, I consider myself like a dementia or a cognitive impairment specialist.
And you are. She has appointments in both neurology as well as in geriatrics. And she is one of the people that I go to first when we talk about, when I'm considering patients on the topic we're going to talk about, which is the anti-amyloid therapy. So as a geriatrician, I see a lot of patients who have cognitive impairment and might be good candidates. But what makes them good candidates? Right.
So the patients that we that benefit the most from this type of treatment, they're patients that have a diagnosis of mild cognitive impairment or mild dementia due to Alzheimer's disease. And the earlier, the better, because those are the patients that benefit the most. And they do have to have some type of imaging or studies that ensure that they do have like the targeted protein, which is amyloid. So either an amyloid PET that is positive or in CSF.
So these treatments are only for Alzheimer's disease, is that right?
That is right. So if we are considering the patient has a diagnosis of cognitive impairment due to something else, then they wouldn't be good candidates because they wouldn't benefit from these type of treatments. Also, if they have more advanced stages of Alzheimer's disease, like if they're moderate or severe, they wouldn't be a good candidate.
And what do these drugs actually do?
So they're monoclonal antibodies against amyloid. And what they do is that they bind to amyloid, to different species of amyloid. We have two types of medications, lecanemab and donanemab. And lecanemab binds to a more soluble form of amyloid, and donanemab to a more mature amyloid, a plaque. And after they bind, there's an immune reaction that makes the microglia in the brain clear the amyloid from the brain.
So the amyloid actually goes away?
It does go away. And actually the medication do that very well. But what we care about is the function, right, and the cognition of the patient. And we know that the medications, they're for patients with Alzheimer's disease, but it doesn't cure the disease. And I think that's important for patients and families to know. But what they do is that they slow the progression of the disease.
So is anybody who has Alzheimer's disease eligible for these drugs? Or, some people, you already mentioned that people who are too far advanced wouldn't be good candidates. But are other people who ineligible?
There is a list of exclusion criteria that we review for these patients. So we also have to think about not just who can benefit from the medication, but also who's at risk of having side effects from the medication. So some patients that wouldn't be a good candidate, for example, patients that are taking anticoagulation, right? So that would be one, or patients that have changes in their brain due to vascular disease, if it's severe vascular disease. because that may be actually causing some of the cognitive impairment. If they had a stroke or a TIA in the last 1 year, also those patients. And then other type of exclusion is if they had a seizure, especially if they had seizures since they're in adulthood. If they have had seizures since they were children, so that might be okay. But especially if they had a seizure in the last 1 year. And I would say that we also want to think about the patients that have ApoE4 homozygotes. So not that they're not good candidates, but we just have to pay attention to those patients because they are at risk of having an increased risk of having amyloid-related imaging abnormalities.
So I'm interested in the first thing that you said was about people who are on anticoagulation. And why would these drugs affect people who are on anticoagulation preferentially?
So exactly, same reason the amyloid-related imaging abnormalities, the ARIA. So it could be ARIA E for edema or ARIA H for hemorrhage. So one of the risks is swelling and bleeding in the brain. So if they're already at risk of having bleeding, right? So they're on anticoagulation, then and then they might be at risk of having ARIA H. So that's not a good combination.
Got it. So these, how often do these side effects occur?
So it depends on the status of the genotype. So that's what we like to check, actually, the ApoE genotype. So we all have 2 alleles, right, from mom and from dad. So then we have ApoE2, 3, or 4, right? And if we have 2 copies of ApoE4, that would be the patient that have the highest risk. And it depends on which medication, but roughly I would say that if patients have 2 copies of ApoE4, they're about 20% of having ARIA. And then if they have 1 copy, 14%. So lecanemab might have a different risk, but that's like the rate for donanemab. And it actually, the risk was less now that we have a different type of dosing. So there used to be a standard dose for donanemab, and then now we have a titration, a modified dose titration would decrease the rate. The majority of patients that develop ARIA, they don't have symptoms. So they were, in the trials, they found they had ARIA because they had frequent MRIs, right, as part of the study. And that's actually what we see in clinical care as well. Most patients do not have symptoms. And if we do catch it in an MRI, we can make changes to the treatment, right? Like suspend or make more frequent, or have them had more frequent MRIs.
So in other words, if somebody has develops one of these complications like the edema, it could potentially, they're not off the drug forever. They could go back on the drug?
If they have one of these complications?
Yeah.
So yeah, it depends on the severity. And I want to clarify also that those percentages that I mentioned were for ARIA-E, and that's the one that we care most about because when you look at the ARIA-H, the patient that had bleeding, only bleeding without the edema, actually the rate was about the same as placebo. So we care about either ARIA-E on its own or ARIA-E with hemorrhage. And in terms of what to do if they present, so if somebody has no symptoms and they have their routine MRI, which they get about 4 MRIs in the first 6 months because that's when the side effect, the ARIA, happens more commonly initially. So if they had ARIA in their MRI, then we categorize by severity in terms of mild, moderate, or severe. So if they have no symptoms and it's mild, then they can continue treatment, but then we have to do an MRI every month. So that's sort of the option, right? Now, we have to talk about this with patients and families, right, to make them aware, and that's fine to do. I mean, we can also suspend treatment and recheck, but it is fine with no symptoms and having mild ARIA to continue. Now, if somebody has symptoms or no symptoms at all, but it's a severe ARIA, then we suspend treatment. We don't restart. And if it's moderate, we suspend and repeat an MRI every month until it's either stable or resolving, and we could restart. And those are the tricky conversations, right, to when to restart.
Spent with patients who are going to be receiving these drugs or are receiving them. And most geriatricians and almost all primary care docs don't actually give these drugs. So at the time of referral to you, what do you like to have in hand?
So many of these patients have been waiting for some time, right, to come and see a specialist. So I think primary care and geriatricians have an important role to maybe start that process and having, if they can, right, I think an MRI, right? So definitely having an MRI within the last year. If it's possible to do an ApoE genotype, I think that's going to be really helpful because we can talk about the possible risk from the medication. And if they had a cognitive screener, I think it's also very helpful for sure and that would naturally occur, right, in an evaluation. So the most common one that we use in clinic is either an MMSE, right, or a MoCA. And the trial didn't use MoCA, but we still use it in clinic, right? And because we're thinking about patients that have a mild disease, so they have to have certain score. And if they have an MMSE of above 20 or 22, right, I think we can consider these patients. For the MoCA, it's a little bit unclear at all the UC system. At UCLA, at least, we have a score of 17 or more. So if they already come with some of these tests done, and we can say, well, this patient is eligible, or or not. I know that not everybody has access, perhaps, to doing an amyloid PET or spinal fluid. Now we do have blood-based biomarkers, and if they have a positive test, right, that'd be also helpful.
So in an ideal circumstance, you'd have everything ready to roll. You'd have the ApoE typing, you'd have a cognitive examination, you would have a blood-based biomarker and an amyloid scan. That would be the best.
That would be the best, but obviously that doesn't happen
very often.
Very often.
Yeah, it's interesting because I think a lot of primary care physicians and even geriatricians don't know that much about the blood-based biomarkers, but they also don't know how to order amyloid scans. They don't even know that they're available and that Medicare will cover them.
So I don't think it's, like if they come without, I often see patients, they don't have those tests, right? Like the amyloid PET, so we would just order it.
And then you do evaluations of patients who are potentially eligible for these treatments, but sometimes you find things that make them not candidates, no longer eligible. How do you tell them that?
Right. So when it kind of depends on the reason why they're not eligible, right? Sometimes actually patients come and they're already in a moderate stage, right? And knowing that, I can tell them that they wouldn't benefit from the medication, and they would just be at risk of having some of these side effects. And in terms of other reasons, like if we find MRI findings, for example, right, that and actually the reasons why we tend to say this patient is not eligible because of we found they have multiple microhemorrhages, right, or one macrohemorrhage. Those are reasons that they would put them at risk of having the side effects, right? So there's always, I would say, a good reason to let them know why is that we are recommending or not recommending something. And it also helps, although it varies by institution, that we have an internal protocol, right? And a protocol that will tell us, okay, these are the right patients and these are not the patients that they would benefit.
And then let's say somebody clears all these hurdles and you've gotten the test that you need. What do you tell them to expect? So many patients come to me and they say, we talk about what they want out of their care. I want to cure my Alzheimer's, is what they say. Here you have a drug that actually takes out the biological marker of the disease and flushes it down the toilet. What do you tell people in terms of what they can expect from these drugs?
Well, I try to be quite honest about what we know from the clinical trials, that what these medications can do and also what they don't do, right? So it's a balance between having hope, right, for the use of these treatments. And usually what I tell them is that there is a medication, right, that will remove the amyloid from the brain, which is the first protein that accumulates in the brain, and then tau accumulates. And because it's early in the disease, that can help slow down the progression. But because we are not targeting the other pathways that occur in Alzheimer's disease, it does not cure Alzheimer's. And then this is actually one of the trickiest questions, right? So how do we explain to patients like what the clinical trials found? So in general, I would say that it's between a 20 and 30% that it slows that decline. And what does that mean? It's hard, right? But we can say that it's perhaps 5 to 7 months behind on the disease progression. Sometimes I also try to explain that it's more likely that they will stay in their current stage the next year, because we also have some data that indicates that, and that's why I was saying that the earliest that we treat these patients, the more benefit that they will get. And then I also manage the expectations about the side effects that we just talked about.
So when they ask you that you're taking this bad protein out of my body, won't my memory improve?
Because it's not just that protein, right? So there is a pathway in the disease, or that we think what happens in Alzheimer's, right? So first, there's accumulation of amyloid, then there's accumulation of tau, and then the brain cells, the neurons they will malfunction and die, right? So then we see the shrinkage in the brain. So because we're not addressing these other things that perhaps already happened, right? There's already tau. There might be already, there are surely brain cells that are malfunctioning. We're not addressing that. So we're preventing from things progressing.
So it's more preventive. You're telling them it's more preventive than it is restorative, in terms of that they would be gaining stuff. And how long these benefits last? I mean, you were saying that it doesn't cure the disease because there are other things that are going on as well, and some damage has already occurred. But the clinical trials are out there. They got FDA approval from that. How long does this effect last?
Well, we have now data from 3 years. So the first trials, we had information of like the first 18 months. So we only knew what happened at the end of 18 months, right? But now there's an open label extension for lecanemab, and now 36 months later, we can see that actually even continuing treatment with lecanemab, these patients can continue to benefit because it sort of stops the amyloid from reaccumulating, and then actually they may gain further slowing of their decline 3 years later. After that, we don't know, right? And that's in the case of lecanemab. In the case of donanemab because that was a different way how they provided the medication, because they could stop the medication early, like at 6 or at 12 months. And even those patients that actually stopped the medication early, let's say 6 months, they continue to benefit, at the end, a year later.
That was kind of leading my next question, is that, at the end of these studies, people could be on in an open label phase, but other people might elect not to, or there might not be an open label phase. The people who had amyloid removed successfully and they're no longer on drug, does it just come back?
It will come back, but it will take probably a couple of years to come back, right?
It kind of resets the clock?
Yes, that's what we say. They're kind of behind when that's sort of what we expect, that they're behind in their progression.
And you mentioned a little bit about monitoring people with MRIs while they're on treatment. Other things do you monitor in addition? How do you repeat their amyloid scans, and when? There was some thought about, if people aren't showing amyloid removal, why continue the drug?
So there's a lot of things to monitor. So definitely we monitor for ARIA with the MRIs, but we also do routine checkups with patients, right, to make sure that they're not having other new symptoms. We monitor them also when they're having the infusion and shortly after the infusion, because they can develop infusion-related reactions. So that's one of the other side effects that can occur. Somewhere between 10 and 25% of patients, they can develop this. But with those, they're usually mild to moderate, and often we can give them a pre-medication. I wanted to mention that before I forget. But the other thing to monitor is an amyloid PET, right? We need to check if the medication is actually helping.
And how often do you do that?
We do it at the year mark.
1 year mark.
Yes.
Yeah. And what happens if they don't show clearing, at least some clearing of amyloid?
So because we can extend the treatment for 18 months, so the FDA approval for lecanemab is 18 months. So even if they show benefit or there's no amyloid at the year mark, we will continue the recommended 18 months. For donanemab, we can do the amyloid PET, and if it's negative, we couldn't stop. And I had actually patients that have stopped at that time.
And have you been able to follow them out, or it's still too early?
We're kind of in the early phase of like some patients finishing. So we need to follow them over time.
They get scared?
I get scared?
Do they get scared?
I think that there's probably a natural feeling of like worrying when they hear the possible side effects. And each person is very different, right? Because some of them are more risk averse than others.
No, but when they go off the medicines.
Oh, I think the patient I'm thinking about, they're and their family were kind of relieved, right? Because it requires a lot of time on their part. They have to come to the infusion, right? They have to come to the visits for the MRIs. So, so I think that patient was relieved, but maybe they do ask the question, will this come back, right?
And so one of the things that's kind of new on the horizon, just recently approved by the FDA, are the subcutaneous. So have you had any experience with it? Do patients like it?
Because we're just having patients that are finishing treatment, I've had those conversations. And I don't have any patients yet on subcutaneous. We talked about it, and actually they preferred to go to the infusion center because maybe they were familiar with it. They wanted to continue. But the family member was a little bit afraid of like the needle, so they just wanted to stay at the infusion center to continue maintenance dosing.
So What's the crystal ball look like? What do you think are going to be the big things that are going to be with the anti-amyloid therapy over the next 2 or 3 years?
Yeah, 2 or 3 years, or maybe perhaps a little bit longer. What I'm very excited about is about learning of the AHEAD trial and the trailblazer for patients who have amyloid in the brain but have no symptoms, right? So that pre-symptomatic. And perhaps we find that the treatment at that stage perhaps averts or really slows the incidence of Alzheimer's disease, and perhaps we're going to be out of jobs, and that'll be good day.
Yeah, so just to put another spin on this, because these are very important clinical trials that are finishing up. They're all recruited, et cetera, and the first readouts may be later this year or 2027. But what Dr. Sanchez Lopez was saying is that these are people who have biological evidence of the disease, they have markers that are positive, and have maintained their cognitive function. So they're cognitively unimpaired. So this is truly prevention.
Right.
This is whether you can interrupt the disease and prevent the development of mild cognitive impairment or dementia. And it's one of these things that keeps me up at night too, thinking about what the possibilities are.
Very exciting. Yeah, I'm actually, yeah, like I said, looking forward to looking at those results, and I do hope that we find positive results.
Thank you. I've learned a lot, and I'm certain that others have. And if you want to learn more, please come to the intensive course in September. There will be, this material will be covered as well as new breakthroughs.